we'll have case selection of echo by Dr. Sameer Srivastav first. I thank him for coming all the way from Delhi for this program. As the starting trouble in our country goes on, I think people will join. So then we'll go on to technique proper, then cath lab like access, and then take you step by step of tower and see the complications session by Dr. Ramesh Dagupati. Request Dr. Sameer to come. Can keep the session. Can keep the sessions interactive. If anybody wants to ask any doubts, feel free to stop and ask. We want it to be more two-way discussions.
Thank you very much, Srinivas. You don't have to be that polite with me, at least. So, and that's something which all of us would want, that wherever you feel that there is any confusion, understanding, please interrupt us and do that shamelessly. So I'm going to start with, can I have my slides up, please? Now, aortic stenosis. Now, I'm going to start with, clearly you find, can we have the lights down, please? Clearly you find that the aortic valve is thickened, it is calcific. There is some mitral annular calcification here. And if you look at it in total, this seems to be an elderly person with a severe mitral stenosis. Let's look at the parameters. The parameters are that his Vmax was 4.6, his mean PG was 52, AVA was 0.7 centimeters square. So clearly he is a severe aortic stenosis. Now, when you come to severe aortic stenosis, fortunately across the Atlantic, there was a very major confusion between the European and the Americans, that whether mean PG of 40 should be taken as a severe aortic stenosis or 50. But now if you look at it across the board, if there is a Vmax more than 4 and mean PG more than 40 and AVM more than less than 1 centimeter square, it is graded as a severe aortic stenosis. But where is the problem? The problem is that this man of ours, roughly, if you look at it by his echo parameters, mitral annular calcification, degenerative aortic stenosis, sclerotic, he would be somewhere in his, he would be an octogenarian or somewhere. But that besides, the biggest challenge is that he's absolutely asymptomatic. Now, asymptomatic severe aortic stenosis, where is the data saying take us to? Because till very recently, conventional teaching was severe aortic stenosis, don't touch them with a mile-long pole. Let's see what the data is. So if you look at the data collected by Otto, whether it was Rosenhack, whether it was Pellica, or whether it was Stewart, everybody showed that as time passes with severe aortic stenosis, there is a decremental survival pattern. So where are we? Are we missing something? Because till very recently, people said, no, they don't die. So if they're asymptomatic, truthfully asymptomatic, they don't die so soon. Now, this is for asymptomatic severe aortic stenosis. So subset analysis came happening, and Rosenhack was a little more robust and more dramatic in approach. They also calculated the calcium score. When they did the calcium score, they found that even for asymptomatic aortic stenosis, look at the divergent graph. Mild calcification versus severe calcification, the survival patterns were so very different. Now, this is severe aortic stenosis, and subsequently, they also started studying what are the gradient effects like in, again, an asymptomatic severe aortic stenosis. Look at the graph. The one in the line is when the Vmax is more than 5.5. And this is the reason why across the Atlantics, both sides, they were forced to change their guidelines and recommendations. Now, the problem is with asymptomatic severe aortic stenosis, and current management challenges are also for low flow, low gradient, and severe AS. So what is the risk of death while waiting for symptoms to trigger AVR? Now, where was the issue? Issue was that natural history of severe aortic symptomatic stenosis was such that if you gave them an option of aortic valve replacement, the chances of dying were more of surgery than leaving them without surgery. So they said, wait till the time they become symptomatic. Now, here is Pai et al.'s. This was not published in Circulation, Lancet, New England Journal. No, it was published in Annals of Thoracic Surgery, because they said this is too dramatic a story in natural history, because everybody who was diagnosed as asymptomatic severe aortic stenosis, from day one, they started dying more. As against most Gang, Taniguchi, Nistri, all of them said that they have a fairly stable period before they start dying more than what the statistics would generate. So this is where Pai's dichotomy was. And now, Taniguchi was even more bold. What he did was, he took two subsets of people with severe aortic stenosis, asymptomatic. One, he followed them up conservatively. Another, he subjected them to surgery. Again, look at the divergent graph. People who had AVR, they survived better. But most of us who are fixated with our own teachings and learnings, they have learned over a period of time, asymptomatic severe aortic stenosis, don't touch them with a mile-long pole. So where are we? Where are we missing the bus? So that subset of population were so immensely impressed by their own thoughts that they did a subset analysis, and they found that 31% of patients who developed symptoms did not have an AVR, and they subjected themselves not to undergo. And this contributed to 17 deaths. So the jury is still not home yet. So where are we? In America, now severe aortic stenosis with Vmax of more than 5 meters per second is class 2A indication. Rapid progression and lower surgical risk, if you have, then this is not that strong an indication, but you can push them across into the eastern side of Atlantic in Europe. Very severe AS, they are a little more conservative than the Americans. They say that 5.5 should be the cutoff, again, class 2A indication. And another thing which they did include was severe valve calcification and rapid progression. What is rapid progression? More than 0.1 centimeter square per year, more than 10 millimeters of mercury increase, or there is a fall of 0.1 centimeter square of valve area in a year. Now, there is yet another developing indications which are entering. That is markedly elevated BNPs. An increase in gradient with exercise more than 20 millimeters of mercury is a class 2B indication. Also, LVH independently is being discussed. Why? I'll come into that issue a little later. So these are the indications. The Americans have really lowered their threshold for surgery in asymptomatic patients. And Europeans, they say that you have to have severe AS, severity of calcification should be included, left ventricular function and exercise response. These are the ones which use. So somewhere the consensus of opinion is developing in the world, and severity of calcification is something which has been done recently, where they found that if for men, the calcium score is more than 2065, and for women, if it is more than 1274, then it constitutes what should be done as an indication for valve replacement. BNP, yes, compared to the baseline population, if your BNPs are more than 3, then it's a softer indication, but yes, it is an indication all the same. These are the ones which are being worked: troponin, soluble, ST2, anti-proVNPs, etc., etc. Now, where are we? These are the values and numbers which have to be calculated in transthoracic. The ones which have really to be done is you have to see whether it's a bicuspid or a tricomistral valve. Bicuspid aortic valve these days is not a disease of the valve. Bicuspid valve is a disease of aorta. It's an aortopathy. And that's the reason whenever there is a bicuspid aortic valve, see this. This is clearly a bicuspid aortic valve, but you go a little down, you'll start finding that this is a fused raphe at the base, at the tip, and at the base, they are relatively free. Now, why is it so important? Because with a bicuspid aortic valve, be very careful to assess the ascending aorta. If your ascending aorta is more than 4.5, this person rather goes for a Bentals rather than going for a TAVI, though the indications are becoming shorter. So here is how you have to take the measurements. You have to take it at the root, you have to take it at the sinotubular junction, and 4.5 centimeters away from the annulus. And this is the place where you'll get the maximum dilatation, expectedly so, just in case dilatation has to happen. This is how you measure beyond, and this is how you take the measurements. Now, to introduce one more term to the fellows, there's something known as low flow, low gradient, normal LV, severe AS. So paradoxical. If the LV is normal, if with it there is a severe AS, why should it not generate gradients? But several times it doesn't. This is known as a paradoxical aortic stenosis. Why does it happen? So there are three reasons why it happens. One is that because of very thick LVH, the quantum of blood which it receives in diastole is so little that for that little blood to eject out, it does not need to have very high gradients. This is the most favored hypothesis. Number two, if there is a person who's hypertensive, the hypertension per se will reduce the gradient across LV to aorta and systole. And third is that you don't know. Maybe the patient had 70% ejection fraction, and now when you're measuring it is 55%. So this person is behaving like a low flow, low gradient, poor LV, or relatively poor LV. So these are three reasons why paradoxical aortic stenosis has to be addressed. And how do you diagnose it? It's very interesting. Start taking multimodality imaging the moment you start finding that there is a LVH in ECG, there is a concentric LVH in echo, the gradients are not high. You do a transesophageal echo, your area is 0.8, gradients are not high. Start utilizing multimodality imaging. Not only did that, CT scan is probably one of the best, because not only does it give you a valve area across the aortic valve, it also gives you a calcification of the valve only. And of course, have your clinical subset well established. Now, what are the outcomes of impact when you operate upon these paradoxical aortic stenosis? If you look at the odds ratio, the odd ratios are favorable for AVR protective, but not significantly so. So again, in this subset, jury is still not home what to do, but the debate continues. Now, just in case, the conventional low flow, low gradient aortic stenosis with poor LV. So if you find that there is a poor LV, start doing a dobutamine stress echo, document increase of Vmax more than 4, document mean PG going more than 40, document falling of aortic valve area less than 1. And if there is a reduced ejection fraction, and of course, the Europeans talk about the contractile reserve. Contractile reserve is that in case your ejection fraction is not increasing by 20% from the baseline, then you are in big time trouble, because not that it precludes you from changing the valve, but what it does is it tells you that the prognostically these people are not probably going to do as well. Now, this is what I just talked about, paradoxical aortic stenosis. It's a very dubious indication. Only if clinical, anatomic, and hemodynamic data supports severe aortic stenosis, then only do it. And unfortunately, when the gradients are not that high, this is going to be a little paradoxical thing to prove. Europeans, as against this, they are more conservative. They say that only after thorough confirmation of severe aortic stenosis should you do it. So this is the time when you should start using multimodality imaging. So how do you diagnose classic low flow, low gradient? Low flow, low gradient, poor LV. So you have to have ejection fraction less than 50% and systolic volume index less than 35. How do you diagnose paradoxical aortic stenosis? You have to calculate the systolic volume index less than 35, ejection fraction more than 50, and rest of the things fall in place. But here there is one more important thing, that you have to have thickened valve. The ratio of should be more than 0.5 of posterior wall thickness to left ventricular end diastolic dimension. So this is what is there. And also, if you document myocardial fibrosis on MRI, and if you get a grossly reduced GLS with normal LV. Start suspecting amyloidosis, start suspecting paradoxical aortic stenosis. Good 20% of severe aortic stenosis patients would be amyloid. Not only that, utilize global longitudinal strain, and if your strains are low, then start thinking in terms of paradoxical aortic stenosis. Not only that, do TE for all, because many a times you would be surprised like this. This is nothing but a intramural hematoma, and you can find dissections. We have found here it is again intramural hematoma with some paradoxical changes. This is intimal thickening. There are certain neurodimensions in a setting of TAVR or TAVI, rule out subaortic membrane. Distance of coronary ostia from base of the aortic leaflet should be more than 10 millimeters. Large calcific valvular nodules or not, because this can really alter the geometry of the valve. Highly calcified aorta is a challenge, though it is an indication too. Aortic root dimension should be less than 45 millimeters at the sinotubular junction, because if it is greater than that, this person might as well go for Bentall surgery. Very hypertrophied septum, because these are the ones, the moment you reduce their afterload, changing the valve, this hypertrophied septum starts behaving like a hypertrophic obstructive cardiomyopathy. So you have to be very careful, because post-TAVR, if your pressures are falling, start hunting for LVOT obstruction. Start looking at pericardial effusion and tamponade. If these two are not there, give them fluids, give them norepi, don't give them epinephrine, don't give them diuretics. These are the patients who will worsen with that. And aortic annular size, these are moving targets. 11 to 29 millimeters is the upper limit, but there are valves which are larger than that. There are valves which are smaller than that. So this is a dynamic goalpost. Now, we have lost the race as echocardiographers because CT scan has become the gold standard. Somebody is going to talk about it. But newer softwares are available for quantitative assessment of aortic root. What is needed is T aortic root image with real 3-time T, and just follow a few simple steps, and what you'll get is a cast. And with this cast, you can get the numbers, you can get the diameter, you can get the mean, you can get all the things possible. But again, the paradox is when MRIs in their initial days had to be validated, they were validated against echo. But these days, echo things are being validated by CT scan and MRI. So these are paradoxical things that we all live with. And this is my last slide. Aortic stenosis is a game of sleuth game. It is detection. Don't look at only one thing, because if you look at only one thing, you'll see what you want to see. In the bargain, you can